Hello, everyone, and thank you for joining us this evening for the first week of the Rugby Research and Injury Prevention Group 2025 Summer Lecture Series. It is a pleasure to have you here with us today. We are going to start off with our featured speakers, Dr. Evan Matthews, an Associate Professor of the Department for Kinesiology, the College for Community Health at Montclair State University, as well as Dr. Nicholas Licameli, Physical Therapist and Injury Reduction and Management Specialist of Strength Together Incorporated out of Nutley, New Jersey. Today they will be presenting on blood flow restriction training and its impact on vasculature and autonomic stress. Thank you very much, and please share your screen when you are ready.
Can everyone see the screen? All right.
Yes, sir.
Well, thank you so much for the introduction. It's an honor to be here, and I'm really excited to talk about BFR. It's a cool topic, and it's something I have a lot of interest in. And yeah, so I we'll get right into it. And again, thank you so much for having us. So let me start this here. Can anyone hear Disney music in the background? My three daughters upstairs are listening to. All right, everyone, we're good. If you notice any music, feel free to sing along, but make sure you're muted before you start singing along to the music. All right, so here we are, blood flow restriction and its impact on vasculature and autonomic stress. So I am going to start with a bit of an introduction and just an overview of BFR. And then Dr. Matthews is going to take it from there and talk about more specifics about some of the work that we've done. So, So first, who am I? So I am a doctor of physical therapy, but more importantly, I'm a father of three beautiful girls and a husband of my high school sweetheart. And I'm an owner of a brick and mortar physical therapy company here in New Jersey. And I also have the online company called Strength Together. And yeah, and I dabble in quite a few other things. The BFR Pros is another company that I'm involved with, which brought me into BFR, and a company called 3D Muscle Journey. I'm also their injury reduction and management specialist, and they work with bodybuilders, powerlifters, and yeah, so I keep busy to say the least. But I'm also a professional natural bodybuilder, and so yeah, I think it's cool to BFR specifically that it kind of involves both worlds. I first heard about it in the muscle magazines back in my early 20s, and then it started coming to fruition. More research started coming out on it, and I started seeing it in physical therapy literature as well. So, me being a bodybuilder and physical therapist, I said this is something I need to dive into more. So that's kind of how I got into it all. Okay. So again, the purpose for my part here, I'm going to provide a general overview of blood flow restriction training and offer some practical applications for athletes. Before we start, I like to just quickly explain the difference between principles and methods. And a quote that I really like is methods are many, principles are few. Methods change, but principles never do. And you could think of something like building a birdhouse. You could build a house many different ways. You can have all different shapes. You can have a porch around the thing. You can have a roof that slants certain ways. Those are the methods. Those things you can interchange to get the end result. The principles, though, are the fact that if you turn a screw to the right, it's going to go in. If you turn it to the left, it's going to come out. And the important thing with BFR is that it really just uses the principles of muscular adaptation. It's not some kind of fad or gadget or that you're going to buy on an infomercial late at night or scrolling through Amazon late at night. This is something that works off of the principles of muscular adaptation that already happen. It just kind of enhances those a bit. So the order of importance whenever it comes to strength, hypertrophy, it's important to remember that adherence is the number one thing, followed by volume, intensity, frequency. And this is the muscle and strength pyramid from Dr. Eric Helms. He kind of outlines this nicely because it's important, especially in the fitness world nowadays. There's so much information out there, and a lot of times the things on the bottom here aren't quite as sexy as the things on the top. So it's important to remember that no matter if it's BFR or whatever technique or training method you're using, that adherence is the most important thing, and followed by the rest of these things here. But it's important to remember the order of importance. So just like I said, BFR is not a fad, not some kind of hack. It's just simply using what already happens and just kind of enhancing that. And we're going to get into that right now. So why use BFR? It's funny when you learn about something or you're interested in something, it's easy to want to use it with everyone. When you're good with a hammer, everything's a nail, right? But it's important to understand the purpose of it so that we use it correctly. So if someone is unable to tolerate heavy loads, or someone doesn't have access to heavy loads, BFR is a great way to maintain gains in strength and hypertrophy. Think of it as a bridge to heavy traditional training. That's a good way to think of BFR. It's not something that you want to use every training session for the rest of your life. It's more something that you kind of phase in, phase out, and use if you can't train with heavy loads. So let's quickly just review how the blood flows through the body. I know it's going to be a review for everyone here, but just it's important to kind of set up the rest of the talk. So this is the heart. If anyone didn't know that, now you do. Basically, so the heart pumps oxygenated blood out of the arteries, goes into your tissues. Once the oxygen is used, the blood, the deoxygenated blood, comes back into the veins and gets reoxygenated through the air in the lungs, and then cycles through again. So the velocity of blood coming out of the arteries is much faster than the veins. It kind of trickles back in the veins and kind of shoots out into the arteries. So with BFR, we are partially restricting that arterial flow. We're not completely cutting off blood supply. We're partially restricting those arteries and fully restricting the veins. So blood is still getting to the tissues, it's just not getting out. And the percentage of full occlusion is what we measure to determine the tightness of the cuff, which we'll get into. So just for time's sake, this is just a quick look at how the blood kind of diffuses over the capillaries into the veins. And this occlusion happens even when we don't use a cuff. So as we flex our muscles and we train with resistance and train with load, our muscles are going to restrict our veins. That's why we get that pump. That's why we get those veins popping out of our arms when we do exercises. But the difference between BFR and traditional pumps or occlusion is that once we put that weight down, that the blood flow is restored and that burn stops and the blood doesn't stay in the limb. BFR keeps it there. So after you put that weight down with the cuff applied, you continue to feel that burn. So it kind of prolongs that hypoxic, acidic environment. So it started, Dr. Sato in Japan in the mid-60s. I guess the legend has it he was kneeling down for some kind of religious ceremony, and he noticed that when he stood up, his calves and his legs were kind of numb and felt really tight, and he felt almost like a pump, like he had just worked out. And so he had this idea that maybe restricting blood flow back to the heart from the limbs could have some kind of enhancement or some kind of benefit to strength training. So that's how it kind of all started. So basically, in a nutshell, it reduces the load needed to reach failure and achieve those changes in strength and hypertrophy. And it can do that with loads as low as 20% of 1 rep max. And it also has been shown to have less muscle damage, which is key for athletes that are in season. Because one thing that you want to do if you're in season is you want to maintain strength training for injury reduction, overall performance, but you don't want to be sore when you go into your game or into your match. So BFR is a great option for in-season athletes because you're having less muscle damage. So you're going to have less soreness after a training bout, but you're getting the same. So basically what I was just saying in the previous slide was that BFR is a great option for in-season athletes because it has less muscle damage. And muscle damage is what makes us sore. So by using BFR, we get the same benefit of strength, hypertrophy, without the muscle damage, so without as much soreness. So that's a great option for athletes who are in season. This chart just shows the difference between the oxygenation of the tissues with traditional exercise and with BFR. So traditional exercise is the dotted line. So this area right here where my cursor is, this is where the set kind of gets to fatigue. The burn is happening. Oxygen drops, burn, 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 and then the weight gets put down, and oxygen is blood flow is restored. And then this is a rest between the sets, and then back down. It's burning, and then it comes back up. The solid line is BFR. So it drops here and it stays down. It stays down, right? So that's kind of a nice little visual to just kind of show that. Okay. Is it safe? That's a good question. Obviously, we're applying a pressurized cuff to our limbs. Is this safe to do? Yes. There are a few things you want to keep in mind. Anyone with uncontrolled blood pressure, you don't want to do this with. If there's any kind of open wound or any kind of history of clotting, we don't want to use BFR. If someone is on hormonal birth control, you do not want to do BFR because there's an increased risk of clotting with hormonal birth control. And what you'll see with BFR is an increase in blood pressure and an increase in inflammatory markers. But those are acute. Those things happen. That's what we want. With traditional exercise, the same thing happens. But over time, that's not something that's chronic. So you may see that increase in blood pressure, increase in inflammation in the short term, but that's not a long-term thing. But that's why it's important if someone has uncontrolled blood pressure, you want to just be careful with those patients. This is a nice little chart that we developed with the BFR Pros. For time's sake, I could definitely send this presentation, so if anyone wants to have it to use, feel free. So how do we do it? How we do things is important. Obviously, this person, whatever she's trying to give this little girl, is not going to have the effect that they want by the way she's doing it. So it's important that we know how to do it. So where to apply the cuff? You want to apply it proximally. That means as close up on the limb as possible. That's more to protect the nerves, blood vessels that tend to be a bit more surface level as you go down the arm. There's kind of more meat, more meat up in that area. So that even if you are training something like your grip or your forearms or your calves, you still want to apply the cuff as high up on the arm or the leg as possible. Cuff size, you just don't want something too skinny because you're going to have to really crank up the pressure to get the restriction that you want. So anywhere from 5 to 17 centimeters has been shown to be effective and safe. How tight? This is important. So if you have a machine that can calibrate the pressure, then you want to put it to 40 to 50% full occlusion for the arms and 60 to 80% of full occlusion for the legs. And if before the automated BFR cuffs were around, we would basically do it like taking a blood pressure. We would just measure to see when we hear the pulse, and then when we don't hear the pulse anymore, that's full occlusion. And then we take a percentage of that pressure. That's kind of how we used to do it before the automated cuffs came, which are much more sensitive and reliable. If you don't have a blood pressure or a sphygmometer, if you don't have the automated cuff and you're in your garage and you're just working out and you want to try some BFR, a quick and dirty way to measure pressure would be a 6 to 7 out of 10 tightness. Not that great of a measure, but you kind of get an idea. It should be somewhat tight, but not really, really tight. One way to make sure that you're not going to cause yourself any harm is always take your pulse. If you can feel your pulse, that means at least we know we're not fully occluding your limb. And anywhere from 6 to 7 out of 10 of a rating would be good for just a quick and dirty way to use it with yourself at home. Obviously, if we're using this with our clients or with our patients or with athletes, you want to have a way to measure it so it's consistent. And we know that we're not causing any harm by causing too much pressure or too little pressure. We want to make sure that it's effective. Usually you want to shoot for 1 to 2 exercises per session. Traditionally, we would do our compound lifts in the beginning, squats, deadlifts, leg press, bench press, things like that, and then work with the isolation movements toward the end of the workout with BFR. That's not a set in stone rule, but it kind of makes sense because you won't be quite as fatigued after the BFR. Like that burn is really intense, so you'll be fully attacking your compound movements. Obviously, that's different if it's the in-season athlete, like we spoke about. Then we may want to do only BFR or BFR for a leg press, leg extension, leg curl, and then the workout is done. Something like that. Exercise selection, really the same as traditional training. Like I said, some of the isolation movements tend to be better with BFR. And gravity is a consideration too. I've never seen any actual research on this, but I would imagine if we're trying to make blood pool in a limb, having the arms or legs elevated above the heart may not be a great idea. So maybe exercises that position the limbs in a dependent position, kind of hanging down, may be something that you could consider. I'm keeping an eye on my time here. All right. So when it comes to hypertrophy, um, the kind of trifecta of hypertrophy is mechanical tension, right? So some kind of heavy loading, muscle damage, the breakdown of muscle tissue, and then that metabolic stress, so that cell swelling, the pump. And hypertrophy is non-specific. So as long as we are hitting failure within some reasonable rep range, we're probably going to achieve hypertrophy. It's kind of like that golden retriever puppy or the Labrador puppy that wags its tail no matter what you do. What we see is that when the loads are matched, so when we use light load with BFR and light load without BFR, the BFR seems to perform better. With unmatched, so when we have heavy load training and light load training with BFR, they seem to be equal, which is awesome. For strength, what we see is when the loads are even. So when we do light load BFR and light load traditional training, the BFR seems to have better strength gains. When it's unmatched, so when we have heavy loads without BFR, the heavy loads seem to come out on top, which makes sense because strength seems to be more specific than hypertrophy. So that kind of makes sense. These are just guidelines, everything we just spoke about. Again, I can give you the presentation I have. Just to kind of go through these here real quick. So passive BFR, you can use blood flow restriction training without active movement. Patients who are bedridden or are unable to move their limbs for some reason or are non-weight bearing after a surgery. You can apply a cuff and you can reduce atrophy and reduce strength loss during a period of inactivity, which is really kind of nice, especially in my line of work in physical therapy with patients coming out of surgery. Aerobic training, same idea, less intensity of the aerobic training, but getting similar effects. Pain modulation. This has been, I use this all the time in my office for this purpose. Sometimes you get that real arthritic knee, and the patient, whenever they try to sit and stand or go up and down the stairs, they just feel that achy joint, and they haven't felt a quad burn in a very long time because that joint just kind of takes over all the sensation of the moment. BFR puts all that discomfort right in the muscle tissue. It's a really cool way for someone with painful joints to kind of move that discomfort into the muscle tissue. The elderly, there's some research on that too, which is really cool. Some improvements in strength, decreased sarcopenia, and I think just increased confidence. I think going through doing hard things and overcoming it is an overall positive thing. So putting someone through that discomfort in a controlled environment, I think is a great way to boost some confidence in the elderly. Because a lot of times we underload the elderly and they're a bit hesitant to really push themselves with exercise. Okay, so let's see, just some practical takeaways here, and then I'll pass the mic over. start with low intensities. First time you're doing BFR, you don't have to crank up the pressure to the top limit. 1 to 2 exercises after traditional training should be movements that are familiar to you. Maybe don't try a new movement with BFR. Just change a few things at a time. For powerlifters or strength athletes, like we talked about before, strength is specific. So if someone can't lift a heavy load due to pain or not no access to weights, like in the pandemic, I know there was a lot of that. It's not no problem. Like keep doing your training because there is specificity of movement. So if you can perform your squat, your barbell competition squat with lighter loads and BFR, you're not getting the specificity of the load, but you're still doing the full movement, even though the loads are lighter. And we know that with the cuff, you'll still be getting the benefits of strength and hypertrophy. So strength athletes, powerlifters, totally fine to use BFR if you have to for a certain amount of time because you can still get kind of squeeze out some specificity there. Just quickly, like we mentioned before, with hypertrophy, BFR really shines with this metabolic stress. It makes sure that we're checking all those boxes with the hypoxic environment that we're creating with the cuff. Another great way to use BFR is with deloads. So if an athlete is, we talked about in-season athletes, but if it's a weightlifter and they are doing, say, a mesocycle for a few weeks, and then it's time for a deload, we don't have to take complete time off the gym. We don't have to completely reduce volume and intensity. We can kind of keep doing what you're doing and just drop the load and add some BFR. So we're getting that recovery from the heavy loads, less muscle damage, but we're still maintaining that training. We talked about pain modulation, practical applications in a clinical setting. Just to wrap up here, we usually will start with passive. So it takes someone who, like in this picture here, just had surgery, non-weight bearing, unable to put weight on the limb. We're at risk for some serious atrophy and serious strength loss, which will prolong the recovery process. We put on the cuff, run it by the surgeon, of course, first, make sure the wound, the incision is all closed up, and we can start some passive BFR, then some aerobic BFR, so like on the bike, maybe just some easy work on the recumbent bike with the cuffs on, and then we get into resistance training, and it becomes this bridge from low to high intensity training. If anyone wants to learn more about this stuff, like I mentioned, I work with the BFR pros. This is Dr. Nick Rolnick, and he has a lot of great content. We do have a few courses on the website, but if you do, or if you're interested, this is a special link and my coupon code for $50 off if anyone is interested. And it's for fitness and rehab professionals as well. So last slide here, let's not major in the minors and chase the shiny objects and chase squirrels. We want to not wrap our identities around methods, right? I'm not like the BFR guy. I'm just a guy who uses BFR sometimes. Yeah, we got to make sure that we're principle centered and evidence based. So, and yeah, of course, my girls make it on the last slide.
All right, so I guess I'll take over there. I'm gonna start sharing my screen. All right, so can I just get a thumbs up from somebody? Can you see my screen? Is it all right? Good. Okay, so I am Dr. Evan Matthews, as mentioned before. I'm at Montclair State University. I'm in our exercise science program. Thankfully, Nick went through sort of the nuts and bolts of BFR, as well as sort of the practical application of it. I'm going to get away from that a little bit and talk about a recent research study that me, Dr. Licameli, as well as Dr. Peter Hosick, which is in the audience right now, conducted with a past student of ours, which I'll show in a second on a slide. So we're going to be talking all about microvascular reactivity and autonomic stress. So knowing that Dr. Licameli was going to go into the background of this, I'm just going to keep this super simple for the background. Traditional resistance exercise leads to hypertrophy and strength gains of the worked muscle. Blood flow restriction resistance exercise does the same thing. All right, so that's really what you need to know as far as why we're studying this. And then for me, I'm a cardiovascular exercise physiologist, so I have the interest on the vascular side of things. And so this modality, which allows all these practical applications because of the lower loads, is especially of interest to me because of the vascular side of it, right? It works through vascular stress, essentially metabolic and vascular stress to the muscle that you are trying to change and adapt. And so the aims of the project that we did is to compare the effects of a single BFR resistance exercise session to a traditional resistance exercise session, which is the TRE there, on post-exercise physiology. And there are two primary aims of this. The first one being a microvascular reactivity aim, so it's trying to see what's happening with the microvasculature post-exercise. And the second being the autonomic nervous system. So the autonomic nervous system controls a lot of cardiovascular physiology. So it's an area of interest to me as well. And here is Michael Perlet's future Dr. Michael Perlet. He's now doing his doctoral studies at the University of South Alabama. And this was his thesis project, essentially, at Montclair State. That I'll be showing you some information from. So there is one paper currently published from this, and that's on the microvascular side of things. And so I'm going to start with that, and then I'll be switching into the autonomic function, so aim 2 in a little bit. The basic protocol that we did, we had 25 intermediately trained individuals, so resistance trained individuals, and none of them had prior BFR experience. So you see there 14 men, 11 women. Our exercise protocol, we did a single exercise, so it was back squat exercise. And for the traditional resistance exercise, so essentially our control condition, we did 4 sets of 10 repetitions, 70% of 1 repetition max, and 1-minute rest intervals. For the BFR, we did pretty much the standard that everybody does with BFR. This is meant to be an applied study to compare the post-exercise effects of doing the standard treatment of either traditional or BFR exercise. So with that, 30, 15, 15, and 15 for the repetitions, and 30% of 1 repetition maximum, 1-minute rest interval, 80% occlusion pressure. And you can see here a picture of the occlusion cuffs that we used, as well as our squat setup there. All right, so in order to test the microvasculature, we use a device called a near-infrared spectroscopy sensor. This is a muscle oxygen sensor. So for those who might be more familiar with pulse oximeters, same basic premise, right? It shoots light into the skin and some of it reflects back, and from that you're able to sense oxygen saturation. The difference being this light goes much deeper, so it tells us about muscle saturation rather than superficial blood saturation. The two muscles we looked at were the forearm flexocarpi radialis and the thigh vastus lateralis. One of those being our systemic site, so it was a non-exercising site. So again, we did squat exercise, so the arm is minimally active. The other one being our exercising site, that's the vastus lateralis. So we did a 15-minute supine rest period before doing anything, just to get their autonomic and vascular physiology in a stable state. We did a 1-minute rest period where we called that our baseline. So you can see in this image here, this is the muscle oxygen saturation. We have our 1-minute baseline where it's fairly stable. Then we had a occlusion cuff that inflated, which blocked all blood supply. So this is not doing BFR yet. This is before the exercise, and then we did this again after the exercise. So we did do full arterial occlusion with this. It's just part of the vascular occlusion test. And from the moment of occlusion to the moment of deflation, it's about 5 minutes that we did. So 5 minutes of full arterial and venous occlusion. And we looked at the what we call slope 1, which we defined as the steepest period, the steepest 30-second period of downsloping oxygen saturation. So this is the muscle deoxygenating because it's not getting blood supply. And it is generally considered a measurement of aerobic metabolism because it's the aerobic metabolic systems that are going to be consuming that oxygen. We then, again, after 5 minutes, deflate the cuff and we measure the reoxygenation slope. And specifically, we look at the first 10 seconds here. That is what we call slope 2. This is the measurement of microvascular reactivity. So I'll be talking about both these, slope 1 and slope 2, showing the results here. All right, starting with slope 1, again, this was the deoxygenation slope, the steepest portion of the deoxygenation slope, a measurement of aerobic metabolism. And because it is a downslope, I did maintain the negative symbol for the values. So you're seeing negative numbers. A more negative number then means greater aerobic metabolism, just to keep us straight here. So looking at the leg, this is the exercising muscle. So our local muscle, because it was within the occluded limb and the exercising limb, we see that there is a time effect. So we did two-way ANOVAs here. Time effect where pre-exercise and post-exercise, the traditional resistance exercise being the open bar or the open boxes, the BFR being the closed boxes, the dark boxes, basically the same exact thing happened. Right, which isn't surprising. So post-exercise, the metabolism is higher in the limb that just exercised. Interestingly, I guess that it happened to a similar degree. We did look at men versus women as a secondary measurement or a secondary sort of pass, I guess, at the data. And men did have a greater effect of this, so greater metabolism afterwards, which also kind of makes sense because they tended to have greater resistance loads on them because of higher one repetition max. All right, looking at the systemic effect. So looking at the arm, again, this is a muscle that did not exercise and was not occluded during the exercise. The BFR condition, so the closed dark circle, dark squares there, not a whole lot going on. It did not statistically change from pre-testing to post-testing with the exercise in between. Looking at the traditional resistance exercise, it did, again, this is a more negative value, so a greater aerobic metabolism post-exercise in the traditional resistance exercise post-exercise time point. This, however, was only found in men when we did where we split them up by men and women. So it seems to be an effect that it's happening in men, but not women, at least within our data set. Then looking at the microvascular reactivity. So this is that upslope after we deflate the cuff, allowing oxygenated blood to infuse the limb. With the BFR condition, we see that the slope increased. So this is a greater microvascular reactivity. You can essentially view this as a higher functionality of the microvessels. All right, that's the simple way of explaining it. So post-exercise in the BFR condition, we had an increase in microvascular function that we did not see post-exercise in the traditional resistance exercise condition. So the open squares there. And that was regardless of men and women. And then in the systemic condition, we honestly didn't see a whole lot going on there, which is not super surprising, although there is a little bit of literature to suggest that there are systemic effects of resting BFR, but again, we did not see that in our study. All right, so some quick conclusions from AIM-1, then we'll switch to our AIM-2. We saw that only in the traditional resistance exercise and only in men, greater post-exercise aerobic metabolism of systemic musculature, so non-active muscles, right? So, which is interesting to see because this is a muscle that has no local reason, at least, for an increased metabolism, which also kind of gets us to AIM-2, which I'll talk about soon. All right, so the application of this, potentially application of this, is that TRE or traditional resistance exercise may be better to use, at least for men, if they're seeking body composition changes as a part of their exercise programming. All right, looking at the microvasculature, only the BFR condition saw an improvement in the microvasculature and the function of that microvasculature post-exercise, again, regardless of men or women. So application being those who may be seeking vascular development, maybe someone with an injury where additional vascular development may be beneficial. We'll see. We'll hopefully do some follow-up testing, Dr. Licameli and I, and maybe in the fall, which we'll be talking about soon, Dr. Licameli. So looking at our second aim here, we did collect additional data to make this aim work. So now we have 39 participants, 20 men, 19 women, all still intermediately resistance trained and all still without prior BFR experience. For this, we looked at an ECG signal, so electrocardiogram signal from the Equivital device. So this is a wearable wireless device that provides two ECG signals, and we used it in order to evaluate heart rate variability. Right, so heart rate variability can be looked at in many different ways. We chose to focus on what's called the frequency domain. So we have low frequency, high frequency, and then the ratio of low to high frequency. For those not familiar with heart rate variability, though, your heart rate seems fairly stable beat to beat, typically, in most people. But there's actually subtle variations from one beat to the next. And those subtle variations can be measured, and they are directly related and caused by physiological changes related to breathing and reflex function and some other systems of the body as well. So with all that in mind, the low frequency power, this is doing some sophisticated black box math here. But the low frequency power is an index of sympathetic activity, high frequency power is an index of parasympathetic activity, and then the ratio of those two is kind of a sympathetic to parasympathetic balance measurement. It's not perfect. The people who are purists out there would probably not love the way I described that, but that's sort of the simple understanding. All right, so this second aim is currently unpublished. Just want to put that out there. So I think the conclusions are pretty stable, but we'll see how things go through the peer review process. So looking at the low frequency signal or the low frequency heart rate variability measurement, remember this is the one that is a measurement of sympathetic activity. So pre-traditional, post-traditional resistance exercise, and then pre-BFR, post-BFR. And then we did have the average values in the middle, and then the women in the open circles and the men in the X's. So you can kind of see what's happening with the men and women, so across the sexes. So in both the traditional and BFR exercise, we did see an increase in our index of sympathetic activity post-exercise, which makes sense, nothing surprising there. But the interesting new finding, I guess, is that well, not totally new. There's some other studies out there have done some similar work, but we're the first to do this where we are looking at women as well. But anyways, the important finding, I should say, is that there is a difference post-exercise between the blood flow restriction and the traditional resistance exercise for that time point. So BFR resistance exercise appears to be less stressful than traditional resistance exercise in terms of the sympathetic response post-exercise. When we look at the high frequency component, which again is our index of parasympathetic activity, same story, but in reverse. So we have a decrease in parasympathetic activity post-exercise in both conditions, with a greater decrease in the traditional resistance exercise condition post-exercise compared to BFR. So again, autonomic function is there's a greater stress on the autonomic nervous system post-exercise with traditional resistance exercise compared to blood flow restriction and resistance exercise. And then when we look at the low frequency, high frequency ratio, again, similar story. Both of them switch to a more sympathetic dominant state post-exercise, and the effect was greater following traditional resistance exercise compared to BFR. So traditional resistance exercise, again, more of a stressor on the autonomic nervous system, leading to more sympathetic, less parasympathetic activity post-exercise. And this is not during the exercise. This is post-exercise, about 15 minutes post-exercise, where they have recovered from at least the initial sort of shock of the exercise. They're not fully recovered, but they are at least partially recovered. This one was the only one where we saw a sex effect, but the sex effect was not specific to the exercise condition. This was just a between sex effect. So men post-exercise have greater sympathetic dominance response compared to women, but that's both with traditional and BFR resistance exercise. So again, not specifically, not different between the exercise types. All right, so getting to the conclusions here, BFR exercise is less stressful to the autonomic nervous system than traditional resistance exercise. And as I mentioned, there were already a few studies that have looked in this area, but all of them have been in men. So the new and novel part of this is the fact that this occurs both in men and in women. And unlike what we actually hypothesized, it occurred to a similar degree in both men and women. The applications to this, there could be numerous applications, but the one we are focusing on, at least in our manuscript that we have in peer review right now, is that it may be useful in people who are trying to avoid overtraining or who might be experiencing maybe the early symptoms of overtraining, because oftentimes that is related to an exaggerated response of one or both branches of the autonomic nervous system. So if we can do exercise that's less stressful on those systems, potentially BFR exercise then could help maintain the fitness or even improve the fitness level of the individual while decreasing the likelihood of overtraining or decreasing the progression of overtraining. Just quick list of all the people involved in the study. Again, Michael Perlet was the lead student on the study. I was the lead faculty, but we also had Dr. Hosick and Dr. Licameli, who were involved with this study and throwing out the Montclair State University. So again, we're not too far from a lot of you. A lot of you were just over the river from us. So if there's anything that we can do at any point in time to collaborate or talk about our research or other things we can do together, certainly reach out. But that is the end of my talk.
Well, thank you very much for that amazing presentation. I'd like to open the floor now for questions from any interns, if you will.
Good afternoon, Dr. Matthews, Dr. Licameli, and Dr. Hosick. Thank you so much once again for joining us for our summer lecture series. My name is Asha Gadraj, and I am the 2025 National Study Co-Coordinator of the Rugby Research and Injury Prevention Group, along with Philip. So I guess one question that I do have is that you did mention that BFR can reduce stress on the autonomic nervous system. With these findings, how do you think this could be applied later on to studies on neuroplasticity of different athletes when it comes to these different types of training? In other words, do you think BFR could be positive when it comes to increase brain function, neuroplasticity, and overall mental health?
So I tend to typically physiologists, you're either brain centric or you act like the brain doesn't exist. I'm kind of the type that usually acts like it doesn't exist. So I don't know exactly if I don't know if there's literature on it, and if there was, I wouldn't be familiar with it. But at least in the work that I've done looking at the microvasculature, the systemic effect was not there. So I would have anticipate because the brain is not going to be in the occluded area doing BFR, that it probably wouldn't have a major impact. Now, that's all this research was acute impact. Chronic impacts may be different. So, training versus one session essentially is what I'm saying. So whether or not training is going to lead to other systemic effects or neurologic effects in the brain, I'm not real sure. It's an interesting idea, but I'm not sure.
Thank you so much.
I have a question. Thanks for joining us. My name is Dr. Lucy Dawson. Just recently graduated from the Howard University College of Medicine. And you kind of alluded to maybe wanting to do some additional research in studying the role of BFR in vascular injuries and vascular injury recoveries. So I'm curious if you have considered measuring direct markers of angiogenesis in addition to using the NIRS data, like measuring things like VEGF.
Yeah, it would be great to do so. It's something that would require some grant funds probably to make happen because those sorts of things are expensive typically. Yeah, I would like to, and Dr. Licameli and I had a few emails back and forth, so I don't want to overstate what we are thinking of doing here, but I'd like to study people who have injury. So the people we've studied in this study that we just went through were all people injury-free, healthy. So I want to know, is the microvasculature responding in a more beneficial way with BFR exercise in someone who in the limb being exercised has an injury? Exactly how we would look at the vasculature, we haven't gotten that far. Probably will use NIRS, but hopefully we can also come up with something a little more mechanistic than that that we can maybe put into a grant when the time comes. So get some pilot data initially and then hopefully write a grant. So yeah, blood markers like that would be great to have though.
Thank you.
Yeah, one thing that I just wanted to piggyback off of is when it comes to pain, the whole like biopsychosocial model of pain, how a lot of the patients' perceptions and feelings and approach and mindset to injury and recovery is a huge thing that I deal with every day. And interesting that something like BFR can have an impact on stress and be less of a stressor. And not that someone who's fresh off an injury is going to be doing stressful exercise, but definitely interesting, yeah, and to see down the road.
Hello,
Um,
my name is Nadira Peaks, and I'm a sophomore at Adelphi University. And my question is blood flow restriction generally more effective in lower limbs than upper limbs?
Dr. Licanelli, you want to take that one?
I haven't seen anything that says more or less in either, but that's a great question. It would really depend on the area what the goal is and what area they can't lift a heavy load that would determine that. But I haven't seen anything. There's the difference between upper and lower, but great question.
Thank you.
Good afternoon, Professor Licameli, Professor Matthews, and Professor Hosick. I have two questions actually. I'm currently a student at Adelphi University for nursing, sophomore year. My question is, you said that usually blood flow restriction training is used on the limbs, right? But let's say if somebody has like a shoulder injury or maybe a muscle tear, I mean in their chest and the pectoral muscles, how could I don't think it could be used because there's no way to like wrap around like this because then it would restrict I guess airflow. So I don't know if you have any ideas maybe for like shoulder or chest injuries.
It's a great question, and there's something called proximal hypertrophy, what we see with BFR, and there's some evidence that shows that if we include the limb and so say like the leg, right, and the leg, we can see hypertrophy in the glutes, or if we put it on the arm, we see hypertrophy in the pecs. Now, why would that happen? What we think is you're fatiguing out the distal muscles first. So the quads and hamstrings and the biceps, triceps. So something like a squat, perhaps. So one common compensation that I see in my office for people with knee pain is their squat becomes very hip dominant. They have a real big like hip hinge and their knees don't even bend past 90 degrees, but they complete a full squat somehow. But it's very hip dominant because they're unconsciously avoiding loading the knee. So if you're going through a squat, a couple of sets of squats with BFR, the quads are going to fatigue prematurely. So then perhaps you're leaning more into the glutes as you continue your set. That's one kind of explanation as to why we see that. And same thing with something like a bench press. If you're bench pressing and your triceps fatigue out prematurely, perhaps there's more stress that's going on the pecs. You're probably not going to lift more weight. You're going to lift less weight, but the amount of activation of the pecs is going to increase, perhaps because the triceps are getting pre-fatigued. So great question, and yeah, I would say if you're going to use BFR, don't use it for that purpose of that proximal hypertrophy. Almost use it as like that could be like a cool side effect of it, but the main goal of BFR should be targeting the distal muscles, and then proximal muscles should be more with traditional training.
Got
Just
it. Thank you. Oh,
like
sorry about that.
yeah, I was just gonna piggyback on that. I'm actually, it's really cool that you brought that up because I have this like running list of research ideas, and one of them was to look proximally. Again, I'm a cardiovascular guy, so my interests were whether or not proximal to the occlusion, if there's any vascular effects. There's other vascular techniques where that are well established. Flow mediated dilation, if anybody's heard of that, is probably the most common, where it's you do an occlusion, and then upstream of the occlusion is where you do all the measurements, because that's where the real action occurs. So I would imagine there might be some vascular effects upstream as well. So, but yeah, I had some similar ideas, but just more vascularly and more vascular in my interest. But good question though.
Thank you. My second question was, you had also mentioned in the study that after BFR, acute blood flow, it increased. So I was thinking usually like tendons and cartilage, they don't get that much blood flow anyways. So since there's an increased blood flow due to BFR, could that help heal tendinopathies or things like that?
So that is certainly the angle in which I would sort of suggest it's a possibility. Whether or not it happens, I don't think anybody knows at the moment. But again, more areas of future research. BFR is a pretty wide open area. There is some research, but especially when you go towards the vascular side of things, it's pretty wide open right now. There's not a ton out there, which is fascinating to me as a cardiovascular guy, because it is a vascular test or a vascular technique, right? The whole idea is that you occlude the vasculature, and yet it's pretty understudied, in my opinion. So I don't know. Good question.
Thank you.
Excuse me, can you join freshers? My name is William McIntyre. I'm a senior at Howard University. And my question is, in your presentation, the first one specifically, you mentioned that BFR training results in less muscle damage, making it essentially like beneficial for in-season athletes. And you also touched on its growing use in a clinical setting. So considering that the study you referenced used intermediate college students, how would you say like the differences in BFR training protocols when applied to athletes versus deconditioned population of students or just adults in general?
Yeah, good question. It really depends on where they're coming from and what their ability is coming into my office. So if we want to lift as heavy as we can, if we can. So if someone is very deconditioned, and then we may start with more the passive BFR, more sedentary, maybe isometrics. We also use NMES, so neuromuscular electric stimulation, people after ACL reconstructions, knee replacements, when that quadricep just isn't firing, like they're telling it to fire, but it's just not moving. So we put on the NMES with the cuff. So we're doing isometric exercises with the cuff because that's really all I could do. But then as they get better and better, once they start contracting that quad in that kind of isometric position, then we swing them off the table, and they can do some like knee extensions off the table. Once they can tolerate some load with that, then we move on to a leg press or something like that, for example. So it's almost that progression. Like once we use BFR until we don't need it anymore, and then we kind of progress past that. And then athletes, yeah, really depend on what the goal is. If I think for in-season athletes, some kind of resistance exercise is probably going to benefit them. Maybe not quite as intense, as intense as the off season, but it's good for injury reduction, strength, hypertrophy, to help them stay resilient throughout the season. And yeah, so BFR, I would suggest, kind of like I mentioned, maybe instead of back squats, deadlifts, maybe we move to the leg press and we just use the training for strength and hypertrophy. One of the things that I think in my profession that we do wrong a lot is we try to combine the field sport with the training. And I think we end up getting the worst of both worlds. We end up having people balancing on Bosu balls doing squats because they're a soccer player, rather than have them in the gym, do their exercise, and then have them on the field and do their skill work. So I think, especially in season, put the cuffs on, just do some straight up, nice controlled, maybe leg presses, and then a leg extension, leg curl, and kind of be on your way back to your field work or recovery, sleep and nutrition and de-stress.
Thank you.
Hello, my name is Philip Tessick, a sophomore at the University of Michigan, and I'd like to kind of piggyback just off of your answer right there. You mentioned a lot of the very subjective feelings of benefit somebody can get when they engage in blood flow restriction therapy, and I was wondering if there is perhaps like a motion to study this perhaps in like a clinical trial to see if those benefits are significant, and a follow-up to that could be, is there a potential of prescribing that sort of therapy for the mental benefit of confidence in a player as they return to play?
That's a great question, and uh, it's funny. I've seen athletes who, and I'm sure many of you have felt this at some point if you played sports or continue to play sports. It becomes your identity. You become a soccer player, you become a rugby player, you become a bodybuilder, you become a football player. And then once that's taken away from you in an instant, the Achilles pops and you're no longer that thing. You have to kind of find yourself again and see, okay, what am I without my craft? What am I without this thing? And sometimes those people who come to me very defeated and just want to feel like an athlete again, having them feel that burn of BFR, even if it's just an isometric quad contraction, like we said before with the electric stim on a few weeks after their ACL reconstruction, that I've just seen their mood completely change, and that just helps us moving forward. That I don't know that I've never read a study on this, but in my opinion, in my experience, I don't know that there's too much of a difference from doing that with BFR versus doing it without BFR. I think just exercise and movement and reassurance and education, um, being in the environment of the clinic, laughing with people next to them. I think all of those things kind of help uplift that spirit, and definitely is crucial to the recovery. I was just saying to someone in my office the other day who I work with, I was thinking, and I said, from the second a patient touches my front door here at the office to the second they leave, there are so many placebo effects going on, like indirect things that make them feel better. Not in like a weird, like trying to get one over on them way, but just everything, like the temperature of the room, the vibe of the room, the conversation, the music in the room. Like there's so many things that can contribute to that what you're speaking to. So I don't know that there would be a difference between BFR and traditional exercise, but it's definitely something interesting to check out.
Thank you very much. Are there any more questions from the team?
I do. How are you, gentlemen? Thanks so much for joining us today. And more importantly, congratulations on the journal article publication. Not only that, but providing us insight on future work that you're going to be publishing on that. Thank you so much for sharing all that. So I'll ask a couple of basic questions, and that is BFR use. It's not supposed to be used alone. It's supposed to be used in conjunction or ancillary. And I guess I'll ask Dr. Licameli, how do you feel that as a solo use of BFR versus its need to be, or in the literature, being supported as being an extra and not a individual application? That's the best way of saying it.
Yeah, great question. I don't know that there is an instance where I would only use BFR because there's always something that we can do on top of it. So, for example, with someone who's recovering from injury or surgery, there are many aspects and many things that we want to improve and train. One of them is just straight up strength. We want to get that quad stronger, for example. But then the other aspect of that is we want to make them function with that quad strength. So things like walking with hurdles or balancing or stability, strategies to negotiate stairs, almost like the skill work, the bringing it back to the function. Those things really have no use for BFR. So I would say the BFR has its place for the isolation, strengthening of the muscle tissue and the joints and soft tissues. But then outside of that, there still has to be that stair training, crutch training, and kind of bringing the strength that we're gaining back into function.
Thank you. And another applicable question for the population, obviously. How long do you think, within reason, should athletes or trainers stop BFR prior to major competitions? Or is there an actual, I didn't see any of the literature support any of that.
Yeah, I think we should look at it just like traditional exercise. It's going to be different person to person. We may have less soreness because of BFR, but ultimately it's going to be getting feedback and working with the athlete and understanding that every day is going to be different. Maybe someone has an argument with their spouse the night before and has a bad night's sleep, and then they come in and they're more less recovered from the previous training bout. And other days they feel great night's sleep, wake up, the sun is shining, and they're ready to go. So I think it should probably just be looked at as normal exercise. Like we should just get
Just
feedback.
heavy training, right?
Yep.
Yeah. And I don't have any problems with that sleeping issue with my wife at all. So in regards to BFR use in elite sports, I've actually seen an abstract that they state that they're using it to amplify warm-ups. What is your view on that?
So I've seen that. And so the protocols are pretty long. They have the cuff inflated for 5 minutes, deflated for 5 minutes, and they usually run it through about 5 times. And they've shown improvements in training bouts that come after that. My question with that would be, so that's a cool thing that we see, but if we're investing that much time with something that's more passive, why not just ride a bike for 10 minutes and have an active warm up? And maybe I would like to see a comparison of the two. Now, one way you could maybe use it if you're in class and you have your practice an hour in the day, and at the end of class you put on a cuff and you have this cycle: 5 minutes on, 5 minutes off, 5 minutes on, 5 minutes off. You get to the locker room, change, start your warm up. Maybe there'll be some kind of effect, but I haven't seen anything that the BFR used as a warm-up is any better than what we've been doing for a warm-up.
Okay, thank you for that. Obviously, you can imagine the practical approach we're looking for. Is it another tool to add to the toolbox? And I guess I'll bring it to Dr. Matthews. Thank you so much, Dr. Matthews, for your insight there. I'll ask you a molecular question. So with brief high-intensity exercise, we know that pre and post exercise glucose levels are pretty much the same. The question I ask you, and I guess maybe you might even want to investigate this, has BFR shown pre and post exercise or pre and post BFR usage, has glucose been manipulated? Is it shoved into the cells? Is it pulled out? Have we seen anything of that, which and therefore would support maybe a warm-up application then?
So I don't know that area specifically. It's not something that I would typically look into myself, but it's based on what we found. I mean, I could theorize how there might be a difference, right? So we see greater systemic aerobic metabolism post-exercise in the traditional resistance exercise versus BFR. So and there's also in part of that second aim is looking at autonomic stress. Autonomic stress is a stimulant of metabolism, which is what I think is largely what's driving that. So traditional resistance exercise is a greater autonomic stress that then drives greater systemic metabolism, which would use glucose as a fuel source, and whether though that would deplete the glucose or be a stimulant for glucose release to increase the blood glucose, I'm not sure.
Again, I think that's an area that would support its application in a warm-up setting.
Yeah.
And I think there's a potential to even look at that. Obviously, we're always trying to see how we can increase our stores pre-competition, pre-performance. I think that's something, an area, probably a new area that maybe you and the team could possibly look at in the future.
That's a good question.
Yeah, I think if you needed a cohort, a population, you let me know. We definitely have a couple of teams we can tap into.
Appreciate that. Thank you.
Yeah, and thank you, everyone. That was a phenomenal talk, and thank you, everyone, for your questions. Anyone else, Pete? I'm sorry, Philip?
Yeah, of course. Minna or Rithvik, do you guys have anything you'd like to add?
Minute can go ahead. I'll go after her.
Hi, I'm Minako, and I'm a junior in high school right now. My question was so traditional like exercise usually like people build up to a certain goal for training, but with BFR, um, does like is there a difference in how long it takes to like for effects to take place, or like does it affect how long it'll take to build up to a certain like weight goal or anything? And you said that BFR is sometimes more effective with older people. Does age take an effect for any of like making certain goals or anything at all? And if so, like between sessions, is there dangers in specific like small changes? Like if like one session we did like a certain weight goal and the next section like we either like didn't remember what the weight was that we used last time, is there dangers in like the kind of fluctuating details?
First, I want to applaud you for being here on uh, Wednesday night at 7:15 at junior in high school. You were well ahead of your years, so nice job being here. The just remind me the first question was time frame of these gains.
Yes.
Nothing really that is blatantly out there as far as like speed of gains, but the BFR you could think of just like traditional exercise, except we're able to use lighter loads and get a similar effect. So I haven't seen anything that the gains in BFR are that much faster than traditional training, but just the fact that you can use lighter load and get a similar effect as training. And then the elderly, can you just repeat your question with the elderly?
Um, so like between like different age groups or each is like between like younger people and older people, is there a difference between like time it takes to get to specific weight goals or anything? Or even like between changes like you make?
Good question again. Yeah, I would say similar to traditional exercise. If someone is a bit older, but they're really in good shape, and someone is really younger and not in that great of shape, I can see the older person maybe making better gains or lifting heavier weight than the younger person. Experience and training is going to have a big effect on the gains that are seen. So if someone has never touched a weight before, if they walk too close to a dumbbell rack, they'll gain muscle. Versus someone who's been working out for their whole life, those gains are going to be much smaller. I don't think there's anything too different with BFR traditional training with age. It's just going to be specific to that person and their training age, their training experience, and overall health. And then, I'm so sorry, the last question.
Like say you make different like changes between session training sessions. Is there any dangers in because like for elder people, I know it's like sometimes we take more caution when training with them, and with younger people, we also take more caution when we're training them in season or out of season. Is there any dangers between sessions that like with BFR since like it's a different like modality?
Yeah, really great question. Um, I would again think of it more like traditional training. So put the cuff on and then start somewhere that seems logical, and almost like I like to use this metaphor when you're adjusting the water in the shower. You put it somewhere that seems logical, but you don't just jump in and start washing yourself. You kind of feel it with your hand, then you feel it with your foot, and then you like get in and you keep adjusting it back and forth. So I would say think of it like that. We're putting this cuff on. It's a new training modality. We're gonna just start easy. We're gonna go through some warm up sets, just get a feel for what it feels like, and then gradually increase the load from there. And then session to session, there's no real danger in like forgetting the weight and then starting with that same process like from scratch again. It depends what the goal is as well. If the goal is hypertrophy or muscle growth, then we can pretty much use a wide range of weights as long as we're getting to muscle fatigue and muscle failure. So if one day you use 10 pounds and you can do 20 reps and you get to failure, and the next day you don't remember what you used and you use 15 pounds instead of 10 pounds, and now you get to muscle failure at 15 reps instead of 20, you're still going to get that hypertrophy effect. I think if your goal is strength, you're probably going to want to keep a closer eye on the load, because that is ultimately the goal, is to lift more load. So you probably want to track it a bit more. And
Thank you.
you no problem. The one thing is you definitely want to keep track of the pressure. Make sure you're using similar pressures every time. If you can calibrate it with the automatic machine, then you want to make sure you're using similar pressures each time and you're not doing too much or too little.
Hey, Dr. Licameli and Dr. Matthews, thank you for the great presentation. My name is Ritvik. I'm a rising senior at Georgia Tech. And two questions I had was, first, so I work as a student athletic trainer for GT basketball, and we actually use BFR with our athletes in recovery. So I found it super interesting. The first question is there like an ideal healing period that you have in your opinion? Like, should we start it immediately after the injury, or is there a certain time period after, or is it just up to the athlete's discretion? Like, what's your recommendation with that? And second question I'd say is there any uses of BFR for high altitude training, like more on like the respiratory or the cardiovascular level? For example, if you don't have access to a high altitude, like let's say we're going to go play Colorado or something, in terms of training for that and on more on like the vascular level, does it help? Are there uses for that? And yeah.
Dr. Matthews, I'll take question one, you take question two.
I could try.
So the optimal healing time. I would say it's going to be different person to person. If the injury is still in the acute phase and there's still swelling around the area, I would probably say let's wait until some of that swelling gets out of there. Not that it has to be completely free of any kind of inflammation, but if it's red, it's hot, it's still swollen, it's pretty fresh, I would say let Mother Nature do her thing there for a little bit until we put on the cuff. If it's a surgical patient or athlete, then you want to definitely make sure that the incision is fully healed before we put that pressure on there. And then you also want to double check with the surgeon. We have freedom to do BFR, but it's because it's that surgeon's patient first. It's just a nice professional gesture. Hey, doc, we're thinking of doing some BFR with this patient. The wound, the incision looks great. Inflammation is down, and I think they would benefit from some BFR. So I think it really depends on what the injury is. But if it's just like a muscle strain or something, and there's no real like swelling or point inflammation, then I would say, yeah, you could pretty much do it as soon as they're ready to do exercise. So just like traditional exercise, if they are cleared to exercise, then you can start some of that BFR.
So as far as the altitude goes, that's a very challenging question. But if I'm understanding it correctly, you're asking if BFR exercise ahead of altitude exposure would improve your performance at altitude. Am I right, basically? Okay.
Correct, yeah.
All right. So keeping in mind that the main detriment of altitude as far as exercise performance is going to be endurance-based sports. So a lot of the stuff we've talked about with resistance exercise and more anaerobic type sport performance that tends to lend itself more towards larger, stronger muscles. It's not necessarily going to apply as well if we're talking about endurance exercise, because that is going to be the primary determinants being your central cardiopulmonary systems, right? So your heart, your lungs. But then also there is that peripheral aspect of the muscles' ability to, once the oxygen is received, to use that oxygen to produce adenosine triphosphate or energy. And that's what allows the muscles to be active and do, the running or cycling, whatever the person's doing. doing BFR exercise is not going to be stimulating those central centers, right? The pulmonary and the cardiac, so the heart. So it's not going to do much to improve that. One of the big adaptations to altitude exposure is also going to be changes in blood volume and hematocrit levels, hemoglobin levels. So over time, an increase in red blood cells and hemoglobin within that red blood cells. I don't see that really happening with VFR training either. Now, if you're doing an activity like maybe cycling, where it is a lot of work on a specific, couple limbs, and it's a little less with the rest of the body, the upper body is much less involved compared to the legs with cycling, where with a sport like skiing or something like long distance skiing, that's much more of a total body workout. So I could see maybe some limb adaptation of the muscle with BFR training. Now, whether there's evidence on this, I highly doubt this has been studied, because in BFR it's a hot topic because there's not all the little nuances aren't figured out yet. That's what makes it a hot topic in research. And it gets pretty specific. So I kind of doubt that's been studied. So I don't know what the answer is. I don't think anybody knows what the answer is. But I would imagine there would be other training. I mean, maybe use it as one of the tools, but certainly wouldn't lean on it as the primary way to ready yourself for altitude exposure. Ideally, giving yourself altitude exposure ahead of when you need that is what you want to do. Specifically more living at altitude rather than training at altitude, because that typically leads to detraining effects. Training at altitude does, just because you can't do as much. Which may also be the case with VFR exercise, at least for central adaptations, again, cardiopulmonary system. So I could see some local benefits. I think you're going to probably get more benefits from other training modalities in exposures, though, is basically what I'm saying then.
All right, thank you.
Interesting question, though.
Hi, thank you so much for your patience answering our questions and thank you for your presentations. My name is Violet Torres. I am a rising junior at Ithaca College. And my question would be, would you recommend BFR training to populations with chronic illnesses like osteoarthritis or rheumatoid?
Great question. Yes, I would. The thing you want to just watch out for with those patients is any kind of comorbidities. So venous insufficiencies, if they have swelling in their lower extremity, arterial insufficiencies, things like diabetes. You want to make sure they have sensation in their feet. So those, if you have just a patient who's overall healthy and has something like osteoarthritis, 100%. That is a great way to make the sensation go into the muscles as opposed to the joints. And I think that's just that mind muscle connection to someone to feel their quads or feel their hamstrings or feel their glutes working when they exercise instead of sharp pain in their joint. I think will be a great adjunct to their overall functional rehabilitation.
Thank you.
And with that, I think we're going to conclude questions for today. And again, as Violet said, thank you very much, Dr. Licameli and Dr. Matthews, for your patience and taking the time to spend presenting and answering questions with us today. We really appreciate it. So with that, we're going to conclude week 1 of the Rugby Research and Injury Prevention Group Summer Lecture Series. We'd like to give a big thanks to Dr. Nicholas Licameli and Dr. Evan Matthews for their great presentation, and everyone in the audience today. Thank you very much.